It's now 9:30. I'll welcome everyone, all 94 of you so far. Thank you very much for joining us for the Moorfield UCL glaucoma seminar. We've got an exciting lineup this morning. Our guest speaker, who I'm not quite sure whether you could hear us talking. I presume you probably could. Our guest speaker was Professor Tien Wong from Singapore, who I'm sure needs no introduction. It's probably the reason why many of you have joined this call. He's the director of the Singapore National Eye Institute and has many leadership positions. Very active clinically and on the research field. His main interest is in retina, but I think if you look at some of the highest impact or highest cited papers that we have in glaucoma, I think you'll find Tien's an author on a lot of those. He's authored well over 1,000 peer-reviewed publications in and in many of the top journals. A true thought leader and an inspirational figure for us in ophthalmology. So in these difficult times, it's great to have Tien here to speak to us about how we're going to handle all of this, but more, more excitingly, really, there are lots of opportunities in the field of AI. His group have been leading the way in terms of retinal disease, and I think many of us who've thought about this appreciate glaucoma is a more challenging area. So Tien's going to be talking to us about that, but also with a positive spin, speaking about why there may be some new opportunities from the pandemic. And after Tien's spoken, we have two presentations from a couple of our fellows at Moorfields. First, Bridget Ning is going to be presenting a case, and then Nitin Big will be doing a journal club on a COVID-related paper. Now, I think the way this system works, rather than having everyone speak, which causes a problem because normally you just hear people sitting their cups of tea and stuff, I think all questions are going to come in through the chat. So when it does come question time, just put them through the chat, and I will do my best to moderate those questions. I think we've got 3 minutes till we're going to start. So I'll put that in the discussion. So I think I'll go on mute. We'll wait just 2 more minutes now, and then I'll introduce you again. So I think it's coming up to 9:35 now. So I'd like to introduce our guest speaker and first speaker, Professor Chen Wong from Singapore, speaking to us about AI in glaucoma. Why is it so hard and new opportunities from the COVID-19 pandemic? Thanks very much.
Okay, thanks very much. I hope you can hear me. So I'm going to share the slides and I'll speak on this. Obviously, a topic that is quite interesting, and I'm going to try to bring in something about the new opportunities from COVID, essentially. Okay, so let me get started, and hopefully this works with this slide here. These are my financial disclosures. I'll get started by saying that, of course, AI, it's a very hot area, and it has been for the last few years itself. And what you've seen is that although it's been around for a while now, in the 1970s already people were talking about AI, machine learning, and many years later, right? So you can see the paper from 1970, and the same author talked about it in 1987 that not much has progressed. So like anything in medicine, you'll find that some things seems like a lot of promise, but yet it's very little change, essentially, right? And what has happened has really Google came into the picture, and of course one of the major developments has been this whole progress that has moved from not just machine learning but to deep learning, essentially. And when you looked at deep learning, what has happened is that it's kind of gone through phases, and I just want to bring you through this because actually there's some transition, but it's very difficult. In fact, I can't make the I can't move the mouse for the transition, so I'm just going to speak about it. Early on, as I said, in the 1970s, 80s, there was a lot of hype about AI, and then a lot of disillusionment when people saying that how come nothing has changed? We have a lot of papers, but very little translation has occurred. And I think that it's going to go through a very slow phase. And I would say that maybe the COVID-19 pandemic will bring an opportunity to accelerate the adoption of digital tools, which is what's been happening. And I think that really presents an opportunity. So the crisis presents that kind of opportunity for us. Now I'm going to go straight into comparing really AI between DR, diabetic retinopathy screening, and glaucoma, and really look at why things are so difficult. Why AI seems more successful in diabetic retinopathy, and if you look at this slide here, it kind of gives you a bit of sense of why I think it has made quite a lot of progress, right? There's a clearly defined gap for screening. It is well recommended. It uses really a single modality of fundus photograph. The diagnosis is relatively simple. You need to label it and you need to classify it, and therefore the training of the algorithm is easier. Some of the algorithms now has been tested in very large and very diverse population around the world, essentially. And really, AI in diabetic retinopathy screening is what I'll call incremental technology, right? You're trying to do something to replace a certain part of the care process, right? And really, for some screening program, it's replacing graders with AI, for example. And then because of that, you're able to do cost-effective studies, and because of that also, you have very narrow but regulatory approval for some of this. And one of the important things is that the impact of it doesn't really impact on retinal specialists. They don't do the screening anyway. So a lot of the drivers for AI in diabetic retinopathy, which is done by retinal specialists driving this process. I mean, in the UK, peers and others do this essentially. In one sense, it's very comfortable with trying to push this because it is something that they like to see, but it's something that's not, in one sense, threaten the retinal specialists. If you look at then the right-hand side, why is glaucoma so hard? Then I think you can see really the counter arguments there, right? I mean, the screening, for example, for glaucoma, there's really been no good consensus about it. A lot of people, in fact, from the early days have argued, why do you want to screen for glaucoma? Because many people, by the time you don't screen them, most people, they don't lose vision until they are really old, essentially, right? So if you screen them at 60, by the time they lose vision, what does it really matter, essentially, right? And of course, there's many modalities in glaucoma. It's not so simple to do an AI because, even the diagnosis is complex. Up to now, there's been, inconsistency in saying who and what and how do you diagnose glaucoma, even for a retinal specialist. I mean, we refer to our glaucoma colleagues who do not agree, essentially, amongst the diagnosis, essentially, right? And therefore, the studies has been isolated algorithms and very different and smallish studies itself. And I would say that in one sense, you're talking about disruptive technology. Why do I say that? Because you're going to have to disrupt two processes in terms of AI for glaucoma. One is that you're going to introduce glaucoma screening as an accepted modality, right? So you're going to have to change the mindset of many people. And then second, you're going to have to bring in AI on top of that. So you're talking about two technologies or two translations you're going to need to do simultaneously. And therefore, because of that, it's very difficult to do like cost-effective studies. So NICE were not evaluated. And of course, because of that, then the regulatory approval becomes complicated. As you already know, even up to now, there's no FDA approval for what is a glaucoma endpoint, right? I mean, intraocular pressure is really an intermediate endpoint, and it's been, in one sense, lucky that glaucoma could, have treatment for IOP, but they can't agree on what's a structural or a functional endpoint for glaucoma, essentially. And of course, the other thing is that, if you really don't know who it is threatening, are you threatening the very people that is going to support it, which is a glaucoma specialist? So I think all this suggests that it is not easy to translate AI technology in glaucoma, essentially. So let me just bring you through a little bit about DR screening first, essentially, right? And then I think then we can go into glaucoma itself. So what do we know about DR screening itself? As I really mentioned, it is very straightforward. There's a clear public health and clinical need. You can really look into where it is trying to impact on, right? So DR screening is on primary care. It is not on ophthalmologists. It's not on tertiary care. And it is really about screening this 400 million people that need screening every year, right? And therefore, I think there is a clear public health, economic, and social, cultural need that people can agree on, essentially. And it's really not controversial at all. It's recommended by everybody that is looking at DR screening. And because this, there's been many screening programs set up. The UK is one example itself. And so I think, and it's based on a single modality of fundus photograph. So I think that that's also easy to do. And therefore, when you're talking about AI, you're really looking at an algorithm that is just going to beat what is currently being done in DR screening, right? So if you have a DR screening with humans, then the algorithm needs to be as good as, if not better than, the human graders, right? That's what it means, essentially. So you have a what I'll call incremental translational technology as opposed to an entirely disruptive technology. And I think that that's important. So if you really want to look at what are the algorithms, so I'll just give you 5, which are the 5, I would say, most kind of well-known or publicized in terms of fundus photograph. The first one, of course, is Google's one that has been well publicized and it's been seen in not just a primary publication, but then subsequently replicated in different cohorts itself. Then there's this IDX, which is really in US, and it is a standalone system. It's also been validated, and the system itself works reasonably well, and there's a commercial opportunity for that. Then there's this iArt algorithm that is also another company. So both of them are based in the US. And I think that, again, they've also done it for different populations. So there's been a lot of validation of their algorithms. And then the Singapore system is something that we've worked on, and I'll show you a little bit of data on that. But I think the first thing that you notice is that it is extremely large and diverse, right? And I think some of the early glaucoma algorithms and the studies has been a little bit smallish in terms of the sample size because of the difficulty of getting very good quality data, essentially, right? So what you see here is about 500,000 images that's been used for both the training as well as for the validation of this study. The algorithm has good AUC and sensitivity and specificity and has been also good, well validated in a lot of external test sets. In fact, we've done some testing in what we call a little bit extreme population, population that does and may require a screening, essentially. And some of the glaucoma algorithms have not been done on this. Most of the glaucoma studies has been done mostly on developed countries like UK, US, in one sense, and therefore the reach and the applicability of the algorithm has not been as useful as what we would like to see, essentially. So when you want to look at the incremental technology, you need to know where does it fit, right? Where does the algorithm fit? And when you're looking at a population, you need to know what's the initial test, what's the existing test, and therefore how do you fit that in? And I'll just show you what it means by that, right? You essentially have two ways, right? You either replace the entire test. So if your initial test refers to some subsequent test, for example, doctors and optometrists need to see it, you either replace the entire test with an algorithm. For example, the Google's algorithm or iArt would be that kind of algorithm. Another way is to triage it. So you use the AI for an in-test in which if it is positive, then you send those kind of cases to the doctors or the optometrists, and that's the value that we have done for our system, essentially. And this just shows you schematics of what happens in our system in Singapore, whereby photographs are taken in primary care clinics, and then the blue arrow shows you that it is sent to a reading center where there's a triage, and then after that, those that are positive are then sent back and referred on, essentially. And if you take a look a little bit at the reading center, what we are saying is that we have used the reading center as a way in which they still does a secondary reading, essentially. So the AI algorithm does what we'll call a triage system. They do not completely do an automated system altogether. And the reason why we've done it is that when we've looked at some of the cost-effective model, unfortunately, I don't have the diagram, can't show it here because I can't do the slide transition bit. But the AI as a triage system had a net saving of about 20%. If the AI was used as a full replacement system, the net saving actually is lower. And the reason is that when you use the AI as a replacement system for the entire grading process, you do need to take into account that you have to set a high sensitivity, but therefore you will lose specificity, right, essentially. And therefore you would send more patients to be seen by optometrists or ophthalmologists. And what it means is that then therefore there's a higher cost to it. So I think when you're using it as a triage, then I think you actually have a way of saving this. Now, what I've done so far, I talk about glaucoma at all, but I kind of shown you the progress of what diabetic retinopathy has made and how the AI system has made some impact there. So let me go into glaucoma and what we think has happened here. I think the first thing, as I mentioned about glaucoma, I'm not an expert in glaucoma, but it is not as simple as diabetic retinopathy, right? There's multi-modality. There are many ways of looking at glaucoma, but nevertheless, the first has been on fundus photograph. In our system, when we started this work, we've also looked at it. One of the things that we've done was that to say, how do we diagnose glaucoma? But in the screening program, we're not really interested in a definitive diagnosis of glaucoma. We are saying, do we want to refer this patient for possible glaucoma, right? And for that, we compared it with a labeling against non-ophthalmologist graded. Fortunately, that of course creates itself some problem because there is very low grader reliability anyway, right? Because most of the graders can't grade and agree on some of the fundus photographs. So I think the training itself was not fantastic, and therefore I think there's some issues with this algorithm, but nevertheless maybe it's all right just for screening. if you look at systems, for example, this by Ming Guang, He, and others, essentially, they much better training whereby they use ophthalmologist graders and look at photographs, and 21 of them, and they took a look at 3 categories, right? Unlikely, suspect, and certain, and you have a little bit higher algorithm. But even then, I think it is not the way to look at training a data set. So subsequent studies, for example, by this group by Wang Ningni in China, suggested a tiered system whereby they used initially students first because they had much more images, and then they used ophthalmologists and the senior glaucoma specialists, and dividing it into unlikely, probable, and definite, and you can see that the AUC goes up considerably. But nevertheless, even then, I think it may not be the way in which you're looking at glaucoma screening, essentially, right? But I would say the AI algorithm did pick up things that humans were interested in. Nevertheless, when you're just using fundus photograph, you have a lot of what we call false negative, essentially, right? And therefore, some of the things is that the algorithms can't pick up things like, for example, pathological or high myopia gives a lot of problems with the algorithms, and therefore I think confounds the ability of the grading system to look at this carefully. So subsequent studies therefore look at what we'll call supposedly gold standard. So what's gold standard? Gold standard means that you get glaucoma specialist clinical diagnosis, right? You need to have the history, the clinical exam, visual field, maybe multiple visual field, and then of course CT, right? And then I think there is a little bit, and you train the fundus photograph to pick it up according to this kind of gold standard diagnosis. Very different from the earlier studies that just look at fundus photographs alone. So I think that made a little bit of improvement from that perspective. And then of course Google came into the picture whereby they used an algorithm and tested it against 3 different data sets, right? One was if they just base it on fundus photographs alone, so they trained something to look at referable glaucoma, and if they compared it with a data set that was trained by specialists looking at fundus photograph alone, I mean, it did quite well. So in other words, if people just want to look at fundus photograph and referred cases there, then I think the algorithms will do as well. But if it is just looking at other diagnoses, for example, ICD codes, it didn't do so well. And if it's based on full clinical workup, then the algorithm is not as accurate as the full clinical workup, essentially. So I think there's some concern there about what whether or not the algorithm does as well when compared to a full glaucoma workup by glaucoma specialists, including longitudinal data. But then, nevertheless, Google also looked at what was the algorithm picking up, and you can see that it was picking up things that was relevant, right, essentially. And I think that that's also quite important, because what you don't want is this black box whereby the algorithm is picking up features that was not relevant for the glaucoma specialist, in which case I think the glaucoma specialist will not this algorithm. So I think this was quite a major paper that came out. Another major development came from the Duke group. Felipe and the team actually did many different studies on it, but this was one of the first study in which they said that how about we use fundus photograph, but we train it with labeling from OCT, right? And so what they did was that using OCT data, they asked the machine to learn using OCT as gold standard whether they can pick up fundus features, and predict with sufficient accuracy. And you can see that the algorithm is also quite good. Not only that, it really could predict the retinal nerve fiber layers quite well, so suggesting a possibility that you may not need OCT, right? If you just have fundus photograph, it can give you a good estimation of the retinal nerve fiber layer thickness. I think that that has been quite an important advance there. We actually look at it in our own data sets, and this shows you those that was predicted by the algorithm and those from fundus photograph, as well as those that were from OCT measured nerve fiber layer thickness. So I think fundus photograph in one sense could be a good proxy for OCT RNFL thickness if there's a little bit more validation study. Then there was a very important study, I think another major leap from the Hong Kong group. This is from Clement Tam and Carol Chung from Hong Kong, in which they fed the algorithm with the entire three-dimensional volume cubes, essentially, of the OCT, right, essentially. And it did better than just the two-dimensional scan. So the top bar shows you the AUCs from, if you look at the blue bars, it is from the 3D scans, and the orange lines represents just the two-dimensional scans. And you can see that the three-dimensional scan does better, essentially, in picking up things. And then there are a few studies that also looked at using Humphrey visual field. I won't have time to go into some of this, but nevertheless, I think Humphrey visual field has been a little bit tricky because they are really not that useful for the deep learning process, because deep learning really requires data, not raw data, more than some of the derived data, essentially. So I think there's been a little bit of thoughts behind that. And then a very interesting paper that just came out online 2 days ago, I think 3 days ago, which is looking at IOP and suggesting that maybe by using what you can see here is a phone video of measuring IOP with GAT, and that the mean difference is about 1 mm. So I think I'm not sure whether that's actually that useful. I think the glaucoma people will feel that 1 mm either way may or may not be sufficiently accurate, but maybe it might be all right for screening purposes. But it looks a very elaborate setup, and I think that the more elaborate the setup is, the harder it is for translation, essentially. So let's look at then, therefore, for glaucoma AI, what is next, right? And I mentioned a little again about why is it so hard, and just let's look clearly at why the diagnosis is so complex. And this is something that I think the glaucoma people on this call and the specialists elsewhere really need to think very carefully about them, right? First, it's very difficult for the engineers to come up with a system if that's very hard to obtain that ground truth that you want to really look at, right? You need a very large and therefore comprehensive data set if you want ground truth that includes a lot of things. So if you want a ground truth that has Humphrey visual field, IOP, longitudinal OCT data, then I think it's going to be difficult essentially for that. And I think that there's also a lot of lack of consensus in terms of some of the dyssuspects and glaucoma test optic neuropathy, and I think that that's something that I think the glaucoma specialists need that agreement that in one sense the retinal specialist has no problem, particularly for diabetic retinopathy grading essentially. I've mentioned a bit about where does it fit in before. I think the glaucoma people working with AI needs to understand, is it going to be a replacement test? What does it replace, right? Is it a triaging test? And if it's triage, where do you put it in? At which level in the community do you want to put it on? If it is an add-on test, where would it fit in essentially, right? So I think there's a lot of questions from this that has not been answered. I've mentioned a bit about translation of AI technology, and really there are three big areas, right? One is the practical part of it, right? Where is the gap? Where are you going to fill that gap? Do you have the infrastructure, both the hardware, the software, the IT infrastructure to be able to fill that gap? The second is the technical, which in one sense is the easiest because there are lots of engineers that can do it. But nevertheless, to feed the engineers' data, you need good quality and quantity data, right? And I think that that part here has not been forthcoming in terms of the glaucoma technology. And then there's a whole bunch of what I call the P's, the public, the patients, the physicians, and providers, right? Social, cultural issues that's not been easy to address. I think what has happened is that you will see that in and after COVID, there's going to be several new normals that provides the opportunity. One is that patient safety is very critical. And because of this, there's been a thought that, the less they go to hospitals and clinics, the less contact, the less time they're there, it is much it's better for patients. Of course, you also want to protect the healthcare resources in times of stress. So in other words, if you have AI, you have digital technology, then maybe you might not need the physical examination as much, essentially, right? The whole idea of staying at home, safe distancing, I think it will be a long time before people start thinking that, you know, it's all right to just go to the hospitals. There's also some interest in terms of public acceptance of digital technology. There's been a lot of debate, in fact, a shift even in very democratic countries. For example, Australia and UK is going to be looking at that. Australia and New Zealand has suggested that societal rights is more important than this individual rights, which actually favors AI technology, right? Because in the past it's been impossible to get some data sharing and so forth. And then, of course, there's new financial and fund models. I'm sure the funding agencies would like to really relook at how they fund healthcare, essentially, right? So if you take a look at what has happening, and therefore there's been a whole sense that of going into telemedicine, teleconsult, video consults. I think it will persist and it will increase over time and will allow us to build an infrastructure, the IT infrastructure, and that digital models that allows us to do AI translation. There's been a lot more ideas about patients' perspective and acceptance, particularly with teleconsult, video consults. I think Morpheus is doing quite a lot of that, and I think that that's quite important from that patient's perspective. There's also been a lot of physicians and providers buy-in. In fact, a lot of agencies around the world are now having a lot of agility and really speed in terms of approving new technology, whether it's for tackling COVID or it's going to mitigate some of the effects of COVID. So I think that the important environment for us to be able to operate on AI. So let me conclude this, I would say, very, you can say, hastily put up talk. Partly, I want to put in new content to say that it is, of course, an exciting technology. It seems that we were going to do this translation a little bit slowly, right? Because it's not easy to translate this because there's a lot of doubts about it and so forth. AI in glaucoma has some progress, and maybe for some specific tasks there is that possibility, but we need much better data, much better consensus on the diagnosis, and there's, of course, all the issues that I mentioned about for glaucoma itself, which does not present for other technology, for other disease like diabetic retinopathy. But basically, the opportunity to really ramp up AI has never been better in one sense, because I think that just any crisis has hastened technology. In the wars and all the other pandemics that has happened, I think COVID-19, that this pandemic will hasten tele-ophthalmology, digital technology, and of course the use of artificial intelligence to kind of mitigate some of the effects that we'll see in AI. So I think with that, I'd like to thank Anthony for the chance to share. This is the Singapore National Eye Center, and of course, hope you can visit if you are able to travel to Singapore one day in the future. I haven't seen this for a while anyway, since all of us are stuck at home anyway. So I'd like to again thank you and for this opportunity to share, and of course, I'm happy to take some questions from this. Thank you very much.
Fantastic. Thanks very much, Chien. When we use Zoom, we could ask everyone to unmute and applaud you, but I don't think we can do this with this system. So, but I can tell I think we've had constantly at the capacity. It didn't seem as though we could ever get over 168 participants, but that was a fantastic talk. Lots of food for thought. Oh, there's some applause coming in on the chat. So. Hopefully some questions soon. Maybe I could ask the first question. So I think it's certainly convincing, like you say, if there's a straightforward task that a human grader can do, like grading diabetic retinopathy, we can imagine a computer taking that over quite well. Now, but one thing some of us are hoping for, I think, is that maybe the machine will be better than us or superhuman in some ways. And one of the AI findings that seems to have got a lot of press and has got people very impressed even though it's completely useless, is the algorithm that can tell you whether you're a man or a woman from the fundus photo. And most of us can work out whether someone's a man or a woman without the need of a clever algorithm. But I think most of us can't do it from the fundus photo. So it's it's seeing something we can't. So my questions are: Do you know what the algorithm is seeing in the retina? And two, do you think there is hope for something that, as you say, rather than a drift, it's going to be like a real shift, a real paradigm change in the way we manage things?
Yeah, I think you asked a good question, and I think that in fact I wasn't. It was a very news, of course, a media sensation when Google, had the algorithm that could predict men and women with 97% accuracy. That everyone's kind of like looked at, and of course, most of us, in fact, all of us, I'm sure, Anthony, yourself, myself, we can't tell, whether it's a man or woman from the fundus photograph. So we know that they are looking at something. I don't think that has made it positive actually for AI, because that has really suggested that it's picking up things that may or may not, is too much of a black box, essentially, right? No one knows what it means. If you look at the recent Google paper, whereby when it looks at glaucoma, and it was mostly picking up a large cup-disc ratio, which has the strongest predictive value, and then notching, and then the retinal nerve fiber layer defects that they see from the photographs. I think that was very comforting, is that right? So if the AI algorithm was thinking like a glaucoma specialist and picking up the signs that we all want, then I think we are very happy, and we will likely let them use it, essentially, right? And so over time, I think that paper was quite substantial. Whereas the black box stuff, whereby no one's like as I said, the Google predicting gender was actually a step backwards, because I think people were much more skeptical, and they don't really want to know why you're picking up things that no one knows about, essentially. So I think it was a very amazing, powerful rhythm for them to have done this. But it was not good for translation, essentially. But I think that this is where things are, essentially. Let me just, I see one question there about glaucoma, about not just how we diagnose, but maybe how we define glaucoma. I think that's an important question, right? Because at the moment, my sense again of this whole glaucoma conundrum, right, on AI, is that there's been very little agreement, even in glaucoma specialists, right, as all of you know. What, how much stuff do you need to diagnose glaucoma, and does it make a difference in terms of long-term outcomes? So I would say that if you have a cohort of patients that you're able to follow up for large enough, that shows good outcomes, let's say 10-year outcome of visual field loss or something like that, right? Tunnel vision, something that is significant to the patient, and you're able to then go backwards and train, some of the modalities, then you might be able to say that these are the things that I want to do to diagnose or define glaucoma, rather than at the moment, have a little bit of uncertainty in that definition. So I think that that's where something could be made. Unfortunately, this kind of data sets is very difficult to obtain, right? And usually it's not large enough in single centers, long-term follow-up for some of the deep learning algorithms to be able to exploit. So I think that that's exactly what one of the problems is.
Yeah, thanks, Jen. I agree. And not only is it the length of follow-up we don't have, everyone's treated, so we don't know whether the treated people that haven't got worse, whether they just haven't got worse because they never had glaucoma in the first place. So we have another question from Diana, who's asking to clarify where you think AI might be a disruptive technology in glaucoma rather than incremental.
Yeah, and I mentioned this a little bit, but let me just maybe highlight it again. I think at the moment, as you know, there's been no uniform consensus of glaucoma screening, right, in the community. You know, maybe you might say, you know, people with a family history should have some screening, but how often do you have screening? And what do you use for the screening, right? We already know from very fundamental work from Quigley and L. Summer that, you know, you can't use IOP, you can't use Humphrey visual field. You know, I'm now talking about my lack of knowledge of glaucoma, so I hope you forgive me, essentially. But I think even from those early days, we know that, you know, you put you know, in the community, let's say they want to screen for diabetes or for hypertension, and you say, I'll put a tonometer there, right? Essentially, it's useless, essentially, because the amount of false negative and positive will make it useless for you to screen. So in other words, you have not yet gotten an agreement of how to screen, with what technology, or what method, and how often do you screen, which population do you want to screen. So you need to tackle that first. At the same time, you want to say, I want to use AI to replace or to assist in screening, right? So that's what I mean by disruptive, because you really have to make two jumps for you to be able to bring that technology in. Because not only do you need to convince, let's say, regulators that you need to screen, you also need to convince them that I need a technology that is going to be able to screen, right? So this is two jumps that is very difficult, all right? What diabetic retinopathy has been different is that it's now, for diabetic retinopathy screening, it is a single jump, incremental, right? Because you already know in UK and in Singapore that there are human non-ophthalmologist technicians that is doing the screening, right? And it is quite well regulated. It is ongoing for the last 10 years. And so therefore, if you replace a single task, which is that you need a human to read that photograph and to classify according to the scale in UK or Singapore. But if the machine can replace that task, then, and if you are able therefore to say, what is the effectiveness of that task? What is the cost of it? What is the cost effectiveness? And therefore, I think regulators and physicians and patients could be saying that, okay, we just allow that technology to overtake that, and therefore it's a really incremental technology, right? And therefore it is actually easier for AI to do this, essentially, right? So I think that's what I'm thinking in terms of that you know, the discussion between disruptive or incremental.
Brilliant. Thanks very much indeed, Tien. You just got a thumbs up there for your answer to that question. Okay, well, I think that's all we've got time for the Q&A, and we'll move on to our other presentations. So once again, some virtual applause for you. One of your former fellows in Singapore just said, "Great talk, thank you."
Yeah, I know. Yeah. We, in one sense, I think we're doing a lot more of this. I think you know, so it's probably not a, you know, you probably can invite other people quite easily now, essentially, right? And it saves them flying, all sorts of stuff, essentially.
Yeah. Thanks very much. You're very welcome to stay on for the other presentations, although I know how busy.
No, I gotta go. I got something else. All right. Okay. Yeah. I'll see all you guys virtually. I see Ted there, and others are my friends. So I take care, and I will catch up with you in a better day, hopefully physically one day, essentially. All right. Take care.
Okay. Brilliant. Thanks, Tien. Take care.
Okay.
Bye.
Bye.
So our next speaker is Bridget, one of our fellows, who's going to be speaking, doing a case presentation for us, I believe. But I think the presentation was so large, it was going to be hard to put onto the system. But Bridget, have you managed? Can you share your screen?
Just sharing it at the moment.
Okay. Thank you.
You see
it? Yeah. It's come up, but it's come up with your. You need to share the screen that's got the presentation, or just bring up the presentation on your current screen if you're not on a multi-monitor setup. Yeah, so we can see your screen now.
Okay, fine. Should I just go from here?
But we can't see the presentation. We can only see your. So if you make, can you make your presentation take up your full laptop screen?
I'm on my presentation now.
Oh, something's happening. No.
Mm, yes.
Anthony, do you want me? Oh, I think we're up, aren't we?
That looks good, Bridget. Oh, no.
As
Well,
in
well,
here now. Okay.
that's good.
Okay, fine. Hi, my name's Bridget, one of the fellows working in more fields. So I'm just going to present a case. So this is patient P, who's a 35-year-old lady. She attended A&E with a right-sided foreign body sensation. She otherwise has no past ocular medical history, no past medical history, no family history, and she was not on any medications at the time. So this is a CAS card from when she went to casualty. And on the findings, you can see her visual acuity was sits in both eyes. And there was a query pigment dispersion like pigment on the endothelium query Krukenberg. The pressures were normal at the time, and there was a query about whether there was fine cells in the AC. She was diagnosed with a right conj abrasion and query PDS in both eyes and was referred to the glaucoma clinic routinely. So she attends the glaucoma clinic 2 months after, and she reports ongoing intermittent light sensitivity to both eyes. But she also mentioned that about 3 to 4 years ago, she also had laser treatment to both eyes to lighten the eye color. And initially they were dark brown. And she mentioned that she had 3 laser sessions to both eyes. And this was done in Spain. So on the examination, visual acuity was sits in both eyes, pressures were 14 in both eyes. Some pigment on the endothelium, AC was quiet, but on the iris anterior surface, it appeared very ruffled and the multiple type of appearance with punched out lesions, about 360 degrees on the anterior surface of the iris, and it was same on both sides. There was no obvious transillumination defects, and on gonioscopy, angles were open, very pigmented trabecular meshwork with query pads inferiorly on the gonium on the left side, and the discs were healthy in both eyes, and OCT and fields were full. So I managed to get some pictures of her anterior segment, and this was the right eye. You can see on the left-hand side that she's got a very mottled type of appearance and very lightened iris as well. And on the gonioscopy, you can see that it's really pigmented on the trabecular meshwork. So I managed to get the picture on the other side, which is a bit clearer. And you can see these very patchy areas of depigmentation areas and these cavitations. And that was all along the anterior surface, 360 degrees on the iris. And also this is a gonioscopy of her angle, which shows really pigmented trabecular meshwork, 360 degrees. So it's quite clear that she had secondary pigment dispersion syndrome secondary to the laser treatment she had. And I just want to just briefly touch upon the different causes of the discoloration of irises, which can, or heterochromia, which can be divided into congenital or acquired. And some of the congenital includes Waardenburg syndrome, as you can see in the top right-hand corner with a white furlock, and they can have heterochromia as well as patchy pigmentation on the skin. Another thing such as congenital Horner syndrome, which is shown on the bottom right-hand side. You can see a slight ptosis and meiosis and a lighter colour iris. And also things like Sturge-Weber as well can cause heterochromia, and usually the darker side is the side affected with glaucoma. The acquired causes, as we all know, are PDS, prostaglandin analog use as well, traumatic, as well as Horner's and Fuchs, which is shown in the middle picture, which shows an irregular sized pupil with a lighter colour iris from the inflammation. So, sorry, I had to, because it was so large, I had to go to, I had to separate the two presentations. Seems. you still hear me?
Yep, we can hear you. Very interesting so far.
I'm just going to go on the second part of it because I think that it won't allow me to share it.
Okay.
And the second part is still downloading, which is all the pictures on it.
But I mean, it was working well sharing your screen, or you can't do that. If you just bring it up on your screen, then we could see it.
Let's see.
Yeah.
You see it now?
Yeah, we can see that. You can make it bigger
So,
as well. Yeah, we can
So
see that.
basically, the most conservative option is to use contact lenses to change the color of your irises. But I wasn't able to find any papers regarding using laser treatment on human subjects to change the color of the irises. But there was a paper that was done on rabbit eyes using SLT laser with a 900 micron size spot, and they essentially separated them into two groups. All of them had about 440 laser pulses, and the group A had a lesser energy pulse in comparison to group B, which had 1.5 millijoules per shot. They found that there was no statistically significant change in the IOP pre and post laser. And then when they euthanized the rabbits and nucleated their eyes, and they did a histopathology examination on them, they found that the average pigment density reduction at the anterior layer of stroma was much more pronounced in group B. This was the cosmetic effect of the rabbit's irises. In the top pictures, that's using the lesser energy, and you can see that the effect is less pronounced at day 60. And in the bottom one, they used a higher energy level, 1.5 millijoules per shot, and you can see that the irises are definitely much more lightened after the laser treatment at day 60. There's another technique that I think the corneal surgeons are using to color the eyes is something called corneal tattooing, and essentially it's used for cosmetic repair for disfigured blind eyes. But there has been some cases used on intractable binocular diplopia, as well as using it on monocular diplopia, especially in those patients who have large surgical PI defects. A Korean group did a study examining the long-term. They presented long-term follow-up results for 147 eyes with patients who had corneal tattooing, and all these patients had a stable corneal opacity but were blind as well. And the average follow-up was about 65 months. And the long-term complications were reopacification, increased opacity that required re-tattooing, fading of the color, and epithelial downgrowth, which they felt that was quite easy to treat. Another technique that is more newer is something called keratopigmentation. It's different from corneal tattooing because they're using the femtosecond laser to make a tunnel into the corneal stroma. And this is how they sort of screen for patients and what they exactly do in the follow-up that was proposed in one of the papers that do them quite regularly. And essentially it's just making an internal tunnel in the stroma and injecting the pigment essentially inside the tunnel. And they use microionized pigment, which tend to has less impurities. There was a series of a Spanish group. They were looking at the results, long-term follow-up results for keratopigmentation using microionized mineral pigments in about 230 eyes. Just want to mention that it's very commercially available, this keratopigmentation procedure. But essentially, they looked at these patients and the patients had that for both therapeutic and cosmetic reasons. They found out about 50 eyes had, in 29 patients, had suffered complications. And the complications varied from 49% of them had light sensitivity, 7% had neovascularization, and about some of them had, a small percentage had visual field limitations and also MRI alterations. And in terms of the MRI alterations, in picture A, this patient had Indian ink, and they needed an MRI scan after, and they found that there was a distortion of the globe after having the MRI on the same side. In picture B, they used microionized ink, which is the brown and the black pigment, and it still caused MRI artifacts on the scan. Another way of colouring the irises is to use these cosmetic iris implants that we are all aware about. There are two main ones. One is the new colour irises, which are now withdrawn because of the high complication rate. But the bright ocular implants are still available, and they are advertised as being safe. A Spanish group examined the post-operative complications of using these cosmetic iris implants, where they did a systematic review of 26 studies and 3 videos, including 128 eyes, and they found that about 68% of these eyes required explantation due to complications, and about 43% of them developed secondary glaucoma, leading to glaucoma surgery, most of them. But in terms of complication profile, it's still quite high in both the new colour iris implants and the bright ocular implants, so it's still has a not a very safe profile, and also it's not approved in Europe or USA or New Zealand or Australia, so they are still using them in other areas. So in conclusion, cosmetic laser to iris is a rare cause of secondary PDS. Corneal tattooing and keratopigmentation are not without complications, and although KTP is very commercially available, it still has side effects such as the light sensitivity, visual field problems, and MRI issues. And as we all know, we should caution against the use of cosmetic iris implants because the complication rates are high. That's it.
Great, thank you very much. So I think some people have been sending questions that pop up for just a second and then disappear. So if you do want to send a question, use the chat on the right hand side and press the sort of the speech bubble there, and then a box comes up above it, so you can put in the question there. But you're getting lots of applause but maybe I can't. Was the patient happy with the outcome of their iris color change?
I think they were, but they were still complaining of persistent light sensitivity, and I think she wasn't aware of the fact that you could develop secondary PDS and glaucoma with doing this amount of laser to the irises. So she wasn't really aware of the potential complications, from what it sounds like.
It seemed as though there was some PAS as well, right?
There was,
so
yeah.
It wasn't just pigment dispersion. Well, what causes the continued pigment dispersion after laser?
I think when I was seeing with one of the consultants, we felt that she didn't really have a rise of pressure after the laser treatment, and I think because she didn't have any more laser after that, I think it's probably ceased in terms of the progression of the PDS. But we don't know if she might have some complications later on or pressure problems later, so she's still under monitoring at the moment.
Someone's asked, why did she do it? Yeah. Why did she do it?
It's a popular thing. I think it's very popular amongst the I think France and Spain are doing it quite often. Also in Mexico, it's a cosmetic thing. They just think that changing the color of the irises look much more attractive. It's just purely cosmetic.
We're not going to see it on the NHS anytime soon. Is it legal in the UK?
This type of thing, especially when there's no studies done on it, even on animals, I don't think so it'll be allowed.
And is it an ophthalmologist that does this procedure? Particular procedure?
I think it was an ophthalmologist that did it, yeah, in Spain.
Oh, sorry, I was on mute. Sorry. Thanks very much, Richard. Our next speaker is Nitin Big, who will be doing the journal club today. Thanks.
Thank you, Anthony. I'm Nitin Vig. I'm one of the fellows. Good morning, everyone. So I don't think you'll be lost on anyone in this audience. There's been very widespread change introduced in the last few weeks. The Royal College, in conjunction with PHE, have introduced guidance that protects patients and also staff. It's led to the cancellation of the majority of our elective activity. And as we've progressed through the pandemic, there's been emerging information on COVID-19, and more relevant to us has been the impact on the and the ocular involvement in that element as well. Most of the information coming out has been anecdotal evidence and case reports, rather than large studies because of the nature of the pandemic. But I just want to spend a few minutes this morning discussing a couple of the papers that may be of relevance to us. So I think the concerns of person-to-person transmission are accepted and fairly well understood. There's droplet, aerosol, and fomite transmission that probably underpins the majority of transmission. What's less clear and of relevance particularly to us is the risk that manipulation and examination of ocular tissue poses. It's well known that respiratory viruses historically can induce ocular symptoms before they then present with a chest syndrome, and I think that's well characterized. In previous pandemics, such as SARS, it's understood that predominantly the virus is transmitted through direct or indirect contact with mucous membranes, eyes, mouth, nose, and it's been found that viral nucleic acid is noted in the tears of patients. And I think it's in that context that there's understandable concern around the potential risks of COVID and coronavirus in terms of tear secretions and so on. More recently, there have been reports of conjunctivitis associated with COVID-19, and also additionally, isolated conjunctivitis and soft tissue infections in the absence of any other chest symptoms, so an isolated presentation. I think there's been much reporting of potential deaths caused by unprotected ocular exposure in Wuhan. I mean, although the information on that's not particularly clear, there has been a concern around that, and that's led to or underpinned many of the precautions that have been taken more recently. So there are many uncertainties in terms of ocular involvement in COVID. I think I'll just quickly address a few of them before moving on to a discussion of a paper. It's far from clear how common ocular involvement in COVID-19 is. And it's also not clear what stage of the systemic disease it can present, whether it heralds the start of an infection or it occurs at the peak of the viral load. Interestingly, we don't really know if virus is present in the tears or the tissues of patients with no ocular involvement, and that's quite an important question. For those patients that do have COVID conjunctivitis, how long are they infected and what risk does that pose us, even if their eyes are white? And does ocular involvement correlate with systemic disease severity? So this is the paper that Anthony wanted me to have a look at, and I'll go through it in the next few slides. It characterizes the progress of the first patient in Italy diagnosed with COVID back in January. And this patient had ocular findings which are fairly interesting. So the objective was to present the early detection of infectious SARS-CoV-2 in ocular fluids of the first patient in Italy with confirmed COVID. The patient was a 65-year-old woman who traveled from Wuhan in China to Rome on the 23rd of January. and she was admitted a few days later with a one-day history consistent with coronavirus in terms of a cough, a sore throat, coryza. Of note, she had bilateral conjunctivitis at presentation. A few days later, she developed a fever of over 38 degrees and had some vomiting and nausea as well. So SARS-CoV-2 was confirmed with real-time reverse transcription PCR on the sputum of the day of her admission, and she underwent further testing to confirm the presence of the virus as well. She had full viral gene sequencing and virus isolation on the Vero E6 cell line. A full genomic sequence gained from her samples also. She had persisting conjunctivitis, so an ocular swab was taken on day 3 of her admission, and viral RNA was detected on that swab. And because the authors were keen to see how that detection progressed, they did repeat swabs for the next sort of 30 or so days. In terms of her clinical course, her conjunctivitis improved significantly at day 15 and had resolved by day 20. This slide shows the time of her symptoms and also the nasal swab and ocular swab viral RNA correlated against her symptoms. The number shown are the cycle threshold, and that number is inversely proportional to the amount of virus present, in that it represents a threshold that needs to be crossed with a sort of fluorescence reaction. So the lower the cycle threshold, the higher the amount of virus. Looking at the nasal swab, the virus peaks at day 3 and gradually decreases, and it corresponds to a similar sort of pattern in the ocular swab. However, of interest, at day 22 to 26 in the ocular swab, no viral RNA is detected, and that fits with her clinical phenotype in that she has no features of conjunctivitis. Her nasal swab is negative at that point. However, at day 27, her nasal swab is negative, but her ocular swab is positive, and she's showing viral RNA on that, but again, in the absence of any ocular findings at all. So the next thing the authors wanted to have a look at was whether the viral genomes detected in the ocular swabs represent infectious virus rather than, I suppose, an artifactual finding. And for the first swab that they did, they actually inoculated the cell line and noted a cytopathic effect within 5 days post-inoculum, and that would suggest infectivity rather than a benign sort of shedding of the virus. The viral replication was also confirmed by real-time PCR as well. So I think in terms of the discussion of this particular paper and this isolated case report, it shows the ocular fluids from this patient had a cytopathic effect when they were cultured into the E6 line. And the virus RNA was present around 10 days after the resolution of the ocular symptoms. So when she had white eye, she still had virus that was shedding into her ocular tissue. The authors suggest, and I think quite reasonably, that this case highlights the importance of PPE, not only from a perspective of the ocular surface being a site of entry for the virus, but actually also a source of the pathogen itself and a source of contagion. Obviously, this is a single patient report and it's limited in that respect. It doesn't actually confirm the infective risk of the material detected in the ocular secretions to humans, but I think it is fair to say there is a potential risk, and I think the authors have shown that. Only the first positive swab was inoculated into the cell line, and it's not clear if the cytopathic is maintained at lower concentrations, and they didn't repeat those culture tests and inoculation tests throughout the patient's course. And I think the authors accept there's a need to define the ocular cell types that are capable of supporting viral replication. I think that probably has an impact on the further precautions we'll need to take, particularly in approaching surgery with patients that have recently had COVID or conjunctivitis in the coming months, really. There have been relatively few studies of cohorts and the prevalence of ocular symptoms relating to COVID-19. And I think they are now starting to come out. And I briefly wanted to just spend a few minutes on a study that's come out of Hubei province in the last couple of weeks. This group wanted to evaluate the ocular involvement of patients with COVID-19. It's a small study, only done over a few days, from February the 9th to the 15th, the Sydney Hospital in the Hubei province. It's a study of 38 consecutive patients, retrospectively reviewed for ocular manifestations. The patients were admitted, and they underwent a full review of their clinical features, had the appropriate blood work, and also had reverse transcriptase PCR results from nasopharyngeal and conjunctival swabs. And the vast majority of them also had CT scans to support a clinical diagnosis if swabs were negative. In terms of the findings, there were 38 patients, and in keeping with findings across the world, there was a predominance for male patients with a mean age of around 66. 28 of these 38 patients had positive nasopharyngeal swabs. Of those 28, 2 of those had positive conjunctival swabs. 12 out of those 38, around 30%, had ocular involvement, and that manifested as hyperemia, chemosis, epiphora, and discharge. Only one of them, a relatively small number, presented with conjunctivitis as a primary symptom. The authors carried out an analysis, a univariate analysis, and they found that patients with ocular symptoms were more likely to have higher white cells and neutrophils, CRP and LDH, suggesting a more severe phenotype of the disease. And when they looked at the clinical course of the patients, a higher proportion of patients with ocular symptoms were characterized as critical, requiring ITU admission, compared to those patients without any ocular findings. 11 of the 12 patients with ocular findings had positive nasopharyngeal swabs. And so it suggests an overlap there that only patients with positive nasopharyngeal swabs had positive conjunctival swabs. So just to focus on the outcomes of this paper, around a third of this cohort had some ocular involvement, and this seemed to be associated with blood test abnormalities. It's not clear, but there's a suggestion here that conjunctival involvement may correlate with a more severe phenotype of disease. Certainly there's an association in this cohort with the blood work, and possibly with the clinical course as well, but that's clearly needs a bit more further work. There's a fairly low prevalence, 2 out of 38 of this cohort with positive conjunctival swabs, despite a third having ocular symptoms, and there seems to be a bit of a mismatch there. In terms of limitations, this is a small cohort, and it's a retrospective study, and it has the limitations that come with that. It only really provides a snapshot of patients requiring hospital admission, and it doesn't provide much information or any information on the possibility of ocular involvement in the community and the significance that that might have. There's likely to be patients within the community that don't need admission, that still have some ocular symptoms that aren't fully characterized. Understandably, no detailed ocular examination was carried out, so we don't know if the patients with positive conjunctival swabs had intraocular inflammation or any posterior pole signs. And that work is understandably difficult to do because of the infective concerns. Only a single ocular sample was taken at the outset of symptoms for the majority of patients, but there was some variability in the timing on that. So I think there's probably a higher false negative rate than if there were regular and frequent conjunctival swabs taken there. So the final few slides I want to spend are just looking at glaucoma in the post-COVID world. Clearly, we are going to have to radically change the way we work and think about patient care in the coming months as we move away from the acute pandemic phase. And I think Tien Wong touched on some of this But there's also been in the literature a few editorials that raise some interesting suggestions on how we may alter our working. Virtual clinics have been increasingly used, but there will always be a cohort of patients that require face-to-face reviews. And I don't think we can really get away with that. Tonometry, which is the mainstay of evaluating many of our patients, we need to understand and characterize the aerosol generation within certain ways of doing this. And also perimetry, which the majority of our patients have on a fairly regular basis. Perhaps we'll need to examine how we carry this out and whether it's actually necessary and which patients really need to have it. Gonioscopy, will we have to move to a single-use gonioscopy lens rather than the very nice, expensive MagnaViews or the lenses that we tend to use? I think there probably will be a need to sort of discuss the modes of operation and whether we can move away from operations that require a very intensive follow-up, such as trabeculectomy, and that's a discussion to be had, I think. Patient flow in clinics will need to be evaluated quite carefully also. Perhaps we'll ask patients not to bring relatives. We'll need to consider carefully how waiting room space is utilised and the time patients spend face-to-face with clinicians. So in conclusion, I think it's still very unclear what the significance of ocular involvement is for prognosis and management of these patients. There is a potential risk of contagion from eyes, but it's not yet understood, and clearly further work in this area is much needed. The risks of COVID-19 or ocular otherwise will have major ramifications on how we manage glaucoma patients, and I think that's something that all of us will need to be involved with in the coming months and probably actually the coming years, if and when a virus, until a virus is produced. That's the end of my presentation, Anthony, and just some references as well.
Brilliant. Thanks very much, Nitin. Are there any questions for Nitin? There was a comment from, I think, Renata, saying probably not fewer traps, but more American style of less visits. I'm not sure what that means. Do Americans have less visits?
I've got no idea, Anthony. That wasn't my understanding.
Okay. Yeah.
Renata says yes, they have less visits.
Okay. Yeah, that's something I didn't know. Oh right, week 1 then week 4. Oh right, post travelers. I see. Have there been any studies looking at aqueous, Nitin?
Not that I've seen, Anthony. No.
Okay. Because there's a question about whether doing a phaco is an aerosol generating procedure.
I talked to Harry about. I talked to Harry about this yesterday. I think my understanding, because we're going to start risk stratifying all our surgery if we haven't already, is that phaco is considered higher risk than a trap, and I don't know if that is because of the involvement of the aqueous, or is it because of the machines and the phaco machine generating aerosol? I don't know the answer to that. It seems likely that if there is virus in the conjunctival tissue, that it may be in the aqueous as well, but I just don't have any references to support that. I don't know if that work's being done.
Yeah, I'm not sure that is such a straightforward. I mean, I think mucous membranes and aqueous are obviously different things. But yeah, I think isn't it interesting, all of these papers making it into level journals, and it's all of a sudden when something's completely new and novel, then even an isolated case report becomes important.
So I think you're right. When I was looking at the literature, is that there's probably been a relaxation of the standards given the importance of the current pandemic. There hasn't been a huge amount of sort of large-scale studies of COVID in the eyes. One meta-analysis of the work that has been done suggested that there's actually a very low rate of ocular involvement, sort of 1 to 2%. And I think we're all taking huge precautions at the moment. And I think there is the flip side of that is that we are probably missing ocular conditions, and there are patients that will lose out from the precautions being taken in terms of their long-term ocular health. It's a difficult balance to strike, I think.
I agree. Well, thank you very much. It was a very clear and interesting presentation. So thanks to all our speakers. Today, I think we've consistently had over 100 attendees, and at most 168, which I think is the limitation of the system rather than the amount of interest. So I'm very grateful for all of you coming. We're going to try and do this weekly. I don't know if we'll always be using this system. I'll be guided by our information governance people. We haven't decided on the guest speaker for next week, but it might be someone in-house speaking on a very popular topic. But thanks everyone, and we'll send around the link for registering for next week. Take care. Bye.